Hello folks, I welcome you all to this second session of secondary glaucoma. Hi, I'm Dr. Rashmi Malhotra and I'm assistant professor in DMC Ludhiana. So as we discussed earlier, secondary glaucoma is when there is some pathological condition like trauma, some medication or ocular condition that leads to rise of IOP and eventual damage to the optic nerve. So under that, today we'll discuss about inflammatory glaucoma first, which can be non-specific inflammatory glaucoma, which can be both open angle or closed angle, or specific hypertensive uveitic syndromes like Fuchs uveitic syndrome or glaucomatocyclitic crisis, which is also known as Posner-Schlossman syndrome. Open angle inflammatory glaucoma can be of two types, acute or chronic. The acute open angle inflammatory glaucoma occurs because of trabecular clogging, trabecular edema, or prostaglandin-induced rise of IOP. Whereas chronic open angle inflammatory glaucoma occurs because of chronic trabeculitis and trabecular scarring. The clinical features of acute open angle are almost like acute iridocyclitis, which is associated with raised IOP with open angle of the anterior chamber. Whereas in chronic open angle glaucoma, the angles are open, the pressure is raised, but there is no active inflammation, but the signs of previous episodes of uveitis are present. The management of acute open angle glaucoma is that of treatment of iridocyclitis, that is cycloplegics and steroids, along with medical therapy with anti-glaucoma drugs to lower the IOP by use of hyperosmotic agents, acetazolamide and beta blocker eye drops. Whereas in case of chronic open angle glaucomas, medical therapy can be used, but ultimately these patients may require trabeculectomy and cyclodestructive procedure. Then we have angle closure inflammatory glaucoma. The mechanism of rise of IOP is either with pupillary block or without pupillary block. Now here we need to understand two terms. One is seclusio pupillae, where there is 360-degree posterior synechiae between the border of the iris, that is pupil, and the anterior capsule of the lens. And there is occlusio pupillae, where there is an inflammatory membrane that is blocking the pupil. Both of them lead to angle closure type of picture. So the clinical features are raised IOP, seclusio or occlusio pupillae, shallow anterior chambers. Here under management, first is prophylaxis. Local steroids and atropine can be given to prevent formation of synechiae. But if it occurs, then the curative treatment is medical anti-glaucoma therapy and surgical or laser iridotomy, and if not, eventually filtration surgery. Then we have specific hypertensive uveitis syndrome, under which one is Posner-Schlossman syndrome, which is a recurrent attacks of unilateral acute mild uveitis with secondary open angle glaucoma. The glaucoma occurs because of acute trabeculitis and is generally out of proportion to the inflammation. And then there is a Fuchs uveitic syndrome, which is a chronic low-grade anterior uveitis, which is unilateral and occurs in middle-aged people. It is associated with heterochromia of the iris. There is no posterior synechiae. It is generally associated with complications like cataract and secondary glaucoma. Then glaucoma can also be associated with blunt trauma. There can be many types of blunt traumas or penetrating eye injuries, and glaucoma is one of them. In trauma, the glaucoma can occur because of pupillary tears, iridodialysis, angle recession, cyclodialysis, trabecular mesh of tears, ruptured zonules, or retinal dialysis. The causes of glaucoma after trauma are inflammatory glaucoma, glaucoma due to hyphema, lens-induced glaucoma, angle recession glaucoma, epithelial or fibrous ingrowths, or angle closure due to peripheral anterior. Out of these, the angle recession glaucoma is the most common one. It occurs because of the rupture in ciliary body phase. It has a bimodal onset. It can occur either within an year of trauma or up to 10 years post-traumatic. If there is 270-degree recession, the risk of glaucoma is 5%. And if there is 360-degree of recession, the risk of glaucoma is 24%. In gonioscopic view in angle recession, there is a widened ciliary body band that is visible on gonioscopy. The management of traumatic glaucoma is with medical therapy, that is topical beta blockers and oral acetazolamide. Surgical intervention needs to be individualized according to the nature and site of trauma. Now, this is a very important topic, steroid-induced glaucoma. It is an open angle type of secondary glaucoma which follows steroid therapy. In general population, 60% people are non-steroid responders. There is a 35% of risk of of a person being moderate steroid responder and 5% risk of having high steroid response. The precise mechanism of IOP rise is not known. But the most accepted theory is that steroid stabilizes the lysosomal membranes and inhibit the release of enzymes which break glycosaminoglycans. This leads to accumulation of extracellular matrix and glycosaminoglycans, which leads to obstruction of the trabecular meshwork outflow and hence rise in IOP. The steroid response can be classified on the basis of Armale-Becker's classification. Under Armale classification, the low steroid responders are the ones where the pressure does not rise beyond 6 millimeters of mercury. The moderate response is when the pressure is between 6 to 15 millimeters of mercury, whereas high steroid response is when there is pressure is more than beyond 15 millimeters of mercury. Whereas under Becker's classification, the low steroid responders are the ones where the pressure is below 20 millimeters of mercury. The moderate responders are the ones with the pressure between 20 to 30 millimeters of mercury, and high steroid responses beyond 31 millimeters of mercury. The steroid formulation is also important. The pressure inducing effect of a topical steroid is proportional to its anti-inflammatory potency. The concentration and dose is also related to rise of IOP. Steroid can cause glaucoma after weeks, months, or even years after use of steroid. But generally speaking, the topical steroids can show response within 2 to 6 weeks. The steroid-induced glaucoma can be prevented by judicious use of steroids and regular IOP monitoring. And for the management and treatment of steroid-induced glaucoma, we should stop steroids gradually with proper tapering, and anti-glaucoma medications should be started. Then we have pseudo-exfoliative glaucoma. The pseudo-exfoliation syndrome or glaucoma capsulare is associated with secondary open-angle glaucoma in 50% of the cases. The deposition of amorphous gray dandruff-like material on the pupillary border posterior surface of the iris and ciliary processes. It is more common in females, but glaucoma occurs more commonly in males. The trabecular blockage occurs by exfoliative material. Constant rubbing of iris on lens scrapes the material of the mid-zone of the lens, giving rise to a central and a mid-peripheral band of pseudo-exfoliation with a clear zone in between. On gonioscopy, the sample line is frequently visible. It is managed same as primary open-angle glaucoma. The pressure can rise and glaucoma can occur post-cataract surgery as well. In early phase, it can be because of inflammation, hemorrhage, retained viscoelastic or lens material. In late phases, it can be either tight sutures, excessive cautery, pupillary block or block because of IOL or vitreous, aqueous misdirection or epithelial or fibrous downgrowth. Glaucoma can also be associated with iridocorneal endothelial syndromes. There can be three clinical entities. Progressive iris atrophy, which is associated with correctopia, iris thinning, and polychoria. Chandler's syndrome, which is the most common entity out of the three, which is associated with corneal edema. And Cogan-Reese syndrome or iris nevi syndrome, in which there is tan pedunculated or nodulation over the iris and iris thinning does not occur. The pathogenesis is the abnormal corneal endothelial cells proliferate to form a membrane in the angle of the anterior chamber. The contraction of this membrane leads to secondary angle closure glaucoma. The treatment is generally difficult in these cases and they are usually surgical. Other causes of secondary glaucoma are glaucoma in aphakia and pseudophakia, ciliary block glaucoma, glaucoma associated with intraocular hemorrhage like red cell glaucoma, hemolytic glaucoma, ghost cell glaucoma, and hemosiderotic glaucoma. So the goals of therapy are to maintain IOP below target pressure, to stabilize diurnal curve, and to identify and treat the secondary causes, which is the most important thing. In most of the secondary glaucoma cases, the medications or the medical therapy does not suffice target pressures, and the diurnal variation stabilization is generally not achieved with only medical therapy, and surgical options are frequently required. Now that concludes our topic of glaucoma. Please read the relevant topics from your textbook. Thank you.